Cool. Priorities. Just wanted to do a quick update on where we're at. Almost finished this financial year. Got another month to go, really. In terms of our sort of four key areas, from quality perspective, as you know, we've really demonstrated we support great clinical outcomes for our patients, for our residents. We've got the outcomes registry that Stu will talk a little bit about in a moment. I think we've got that at just under 40 homes now covered and 2,500 residents. There's been some good work this year on palliative care pathway and an increase in preventative care, providing particularly via our geriatricians for the as part of the sort of comprehensive geriatric assessment, which is also strongly linked to improved outcomes for patients, elderly patients. We've got the GP practice accreditation underway, so that's going to help lift our standards, making sure we've got all the policies covered. It includes an audit of clinical notes and so on across all our doctors, as well as a survey of what our patients, our residents think about us and our clinicians. So there'll be a lot of good rigor around that can help us improve. And we've actually had a few presentations accepted at conferences that are coming up. So Anil, our lead geriatrician, is going to be presenting at the ANZ SGM, which is for the Society of Geriatricians. So it's coming up in June, which is exciting. And then we've got 3 papers accepted for the National Rural Health Conference, where they're talking about our hybrid model and how it delivers great outcomes, about how it improves sustainability for GPs who are leaving aged care in droves, and also a poster on the registry and how that's working, which can be valuable for research in regional areas. So lots been happening this year on the quality side of things, and I think we should be very proud of the service that we provide to all of those vulnerable elderly patients out there. As a business, we had strong engagement from our survey last year, and Sarah and the team have been busy doing a bunch of stuff, working with you to make sure there are local initiatives in place to address concerns that came out of the engagement survey. We're working on an HR strategy, so that's underway. As mentioned before, we've seen our retention of clinicians improve significantly this year, which is great because that has a real knock-on effect in terms of the stability of our service, the continuity with patients as well, which makes a big difference. From a leadership perspective, a number of people in this room are on the Leadership and Practice program, which is our second leadership program, led by Luke and Sarah. We're grappling with psychosocial safety, so we'll have a suite of policies ready soon on that, which everyone will need to get across. There's a pulse survey going out soon, I think, in June. And one of the key things that was an issue or a complaint or an area we could do better on was communication. So obviously introduced the town hall, and Sarah will talk a little bit later about some further columns that we're going to be putting in place, weekly columns that will go out to the whole business from covering different aspects of what we do. From scalability perspective, the Clinical Operations Excellence project is up and running. We're piloting Heidi, which is really exciting, which is an AI scribe, which can really help produce higher quality clinical notes and save a lot of time for our doctors as well in terms of the notes preparation. I think we've got about 15 out of the 20 now live on Heidi, which is good. And some of them are using it for 100% of their consults now. So Neil, for example, a lead geriatrician, has gone from not using a scribe at all to 100%. It's just super, super powerful and makes their lives a lot easier. We've agreed to a strategy for our technology platform. We're just finalising some of the elements of that and the cost that we're going to include in the budget for next year, but there'll be a lot of enablement of our clinical teams through that in particular, both with the Heidi thing, but also with looking at ways we can really extract the medical clinical data from Helix, which is our practice management system, and present it in a much more intuitive way to our nurses and clinicians to help them really understand what's going on with an individual patient and what the diagnosis might be and what the right treatment plan might be. Telehealth GP, so that was really put in place super quickly last year, and that had a big impact in the nurse billing percentage that Dave talked about. The nurse app is running. We just have low usage, so we need to work out how we can improve that and get our nurses to use that more than they currently do, because it's pretty helpful, valuable. And as part of the technology strategy, we've been sort of redoing the onboarding process, and that's the first phase of that is rolled out last week, I think. I think without any issues so far. Brendan will talk to this, but yeah, very close to 5,000 residents. So we're just hovering around that mid 4,900s. Density's increased as well, which is really good. Dave covered on the billing cycle and financial initiatives, and the ops team have been just awesome this year in terms of improving ground utilisation, which has helped our sort of consults PRPO, which Dave mentioned as well. And yeah, we've generated our first profit this year as a business. So it's all exciting. But I just wanted to recap on our clinical model. If you want to go to the next page, Sarah. So we've actually come across better data in terms of what the industry does in terms of consults per resident a year. The previous data we had was about half this, it was about 17, not 35, but it included permanent residents, but also respite residents, and it assumed they were there for the whole 12 months of the year. So it gave a much bigger denominator than is the real life situation. When we've found a different way in which the Australian Institute of Health and Wellness have cut the data, which is much more relevant for us. So it only includes residents in permanent residential aged care, and it actually adjusts for the amount of time they're in the home for the year. So we've got some patients who are in there for the whole year, others who come in are only there for part of the year. It takes that adjustment into account. And so on that basis, we're actually, there's been a lot of concern, I think, from nurses and doctors out there that we might be, and from residents, that we might be over-servicing, providing too many consults. But this data very clearly says we're actually average in terms of what we do from a consult perspective. So that's an important message that we need to get out to our clinical teams and also to our residents, our next of kin, and our RACs. If you want to go to the next page, Sarah. And within that, we do a much better job because we have Tom's ticketing system, we have a triage nurses. We do a much better job of actually providing care to those who need it the most. And so when you look at the number of consults per resident per month against sort of 3 different segments, they're very different. So we have stable residents who we see about 2 times a month on average. And then on the other end of the spectrum, residents that are deteriorating or unstable and need a lot of management to get back to health have about 6 consults a month. It's a lot, but it's providing the care where it's needed. And then patients who are at end of life, they have an average of about 5 consults per resident per month. So we're focusing really where our service and our care can have the most impact, and providing that in a really timely way, because we have GPs available, we have geriatricians available, and we have our locum service wrapping around it. So unlike a solo GP practice, we can respond really quickly. And all of that means that, as you've seen before, can we go to the next slide, Sarah? We deliver much better clinical outcomes for our patients than the industry. So 50% lower ED presentations, 37% lower on-plane hospitalizations, and about 19% lower polypharmacy. So that's the number of medications that a resident is on. And we've just developed a de-prescribing program. So I think that should reduce further. Being on too many medications has a really negative impact because they might have interactions amongst them A lot of, when you get to sort of 85, which is the average age of our population, there'll be a number of medications that were prescribed years ago by a particular specialist that are no longer really required. So adjusting that can have big impacts. And we've lost the connection. Anyway, from a, hopefully online they can see, from a cost perspective of the healthcare system, all of that hospitalisation, running hospitals, and in terms of the PBS, so the cost of drugs to the taxpayer. And obviously we're presenting that argument to government, that we have such a comprehensive clinical care model, that we have a big impact beyond what we do on the healthcare system. So any questions on that or those priorities? Online or in the room? Cool, and I think what Stu's going to talk to in a minute around ACORR, so a quality registry, should enable us to improve these outcomes even more, because we can actually, there's quite a spread of outcomes across the homes that we support, and we can learn from those homes that have lower hospitalisation rates or lower polypharmacy, adjusting for the complexity of the mix of patients that are in there. So a lot of potential to even better.